Well, I'm going to transition now to without further ado, but I want to also appreciate Sharon and Shalini and Jaron for that starting activity. So it really is my pleasure to introduce our keynote speaker, Dr. Polly Gibson. And Dr. Gibson is a licensed clinical psychologist and clinical associate professor in the Department of Psychiatry, Child and Adolescent section at Michigan Medicine, University of Michigan Medical School. I'm going to read her whole bio because I just find it awesome and I want to share it with you. She serves as the director of the Trauma and Grief Clinic and the director of promoting resilience and outreach through multi-tiered interventions and supportive environments, which is Promise for Success, a trauma-informed and trauma-responsive community intervention funded by the Robert Wood Johnson Foundation. Promise tackles the wicked problem of child traumatic stress and its impacts on academic functioning. Dr. Gibson is also a co-investigator for an NIH-funded study focused on the warning signs of youth suicide attempters. She is a site principal investigator for a SAMHSA-funded investigation focused on the development of bereavement-informed best practices for youth. She is a member of the Youth and Young Adult Depression and Suicide Prevention Research Program, and her expertise is in evidence-based clinical practices, trauma and bereavement-informed assessment and intervention, suicide risk assessment and intervention, universal screening, brief interventions, and community-based participatory research approaches. Dr. Gibson's activities will continue to focus on implementation science, specifically community-based prevention and intervention strategies for underserved youth at elevated risk for trauma and grief exposure, suicide, and other adverse psychological outcomes. Dr. Gibson, we're really glad we have you here with us today, and we are really, really grateful for you bringing your expertise. Take it away.
Well, thank you. And for all of you that had to sit through that long bio, I apologize. You know, they put these things up, you know, on our websites, and, you know, sometimes it can be a bit much. So I appreciate you reading that. I mainly also want to thank the young ladies that gave us a tutorial on TikTok, and I think I might need a private one. I really struggle there, so I appreciate that. So I'm going to share my screen now and start my presentation. Can everyone see this okay?
Yes, perfect.
Okay, so just for the co-facilitators to know, and sharing my screen, I can't see anything else. So feel free to just interrupt me with your voice. I'm going to set a timer on my end as well, but if you need to, you know, contact me, just please chime in because I'm not able to see the gallery.
Thank you, Dr. Gibson. And just to acknowledge, I know we're starting a few minutes, your time is starting a few minutes later than planned, and I'm hoping we can still save some time for Q&A at the end. So we'll chime in if we need to, but the floor is yours. Thanks.
Yes, and I definitely want to save time for Q&A, so definitely maybe let me know when there's about 10 minutes left. Okay, so I'm going to get on with it. I'm delighted to be here this afternoon with you. Thank you so much for having me. And, you know, I do have quite a bit of information to present, but I will do my best to save time at the end with the help of the facilitators to try to have some discussion. So I just want to start with this word cloud, because oftentimes when we hear the word trauma, it strikes fear, as you can see here. There's just flashbacks, abuse, terrifying events, drug abuse. So you can see that when you hear the word trauma, it has a reaction in people, lay people as well as professionals. But my goal for you this afternoon is for when you hear the word trauma, for you to think about the 4 R's of trauma-informed care. Those are realize. We want to realize the widespread impact of trauma and understand potential pathways for recovery. Recognize. We want to be able to recognize the signs and symptoms of trauma. And in this case, we're going to be thinking about adolescents, as well as the others involved in your healthcare system, as well as for yourself. Respond. We want to respond by fully integrating knowledge about trauma into our policies, procedures, and practices. And the final R is resist re-traumatization. We want to resist the re-traumatization of our patients, as well as others that we care for, and also for ourselves. I'm hoping today that we'll get to talk a little bit about secondary traumatic stress. So that's what I'm hopeful for at the end of the talk. You'll be thinking about realize, recognize, respond, and resist. What is trauma-informed care? Well, according to SAMHSA, it is a strength-based service delivery approach that is grounded in an understanding of and responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both providers and survivors to rebuild a sense of control and empowerment. I really like this definition because it highlights key aspects. In a moment, we'll talk about SAMHSA's kind of guiding principles to trauma-informed care, and you will see that safety is paramount. And so one of the things that we'll be talking about today is how to create a sense of safety for teens when they come into your offices for care. And I think you'll also be doing some other exercises. As you'll see here, it talks about for providers and survivors. So it's important to think about yourself in all of these interactions. And I also like that it talks about how we want to try to rebuild a sense of control and empowerment. We know that for traumatized teens, this is one of the areas that they particularly struggle, is this lack of control. Bad things happen that were out of their control, and they struggle to be able to exert that control in other situations. And the principles will also highlight this need for voice and empowerment. Just the presentation that we just had was very empowering. It involved teens themselves. It allowed them to share stories. It allowed them to tell from their perspective how they view this word trauma and how they're reacting to it. So that was a very excellent example of a trauma-informed approach. So what is trauma to adolescents? The National Child Traumatic Stress Network is an excellent resource that if you're not familiar with, I would highly encourage you to familiarize yourself. The website is just nctsn.org, and I will be sharing some resources later that will have that link. When we're talking about trauma to adolescents, we're talking about when a youth feels intensely threatened by an event such that he, she, or they is involved in or witnesses. So more specifically, we're talking about the experience of a real or a perceived threat where there was threat to their life or their bodily integrity and or the life or bodily integrity of a loved one. So a lot of times when we're assessing for trauma, we're talking about lived experience, but we're also talking about what was witnessed and even what was learned about. So a teen can be traumatized just by hearing the trauma that someone else they cared about was involved in. And or trauma causes an overwhelming sense of terror, horror, helplessness, and fear. So it's important to recognize that it could be one of these things, it could be two or all three, but this is what we're talking about when we're thinking about trauma in adolescence. Why does addressing trauma matter? Well, we know that for teens, obviously, this is a critical developmental period. Teens are going through so many important milestones during adolescence. I like to think of it as them crossing the bridge from childhood to adulthood. And so we know that if they've been impacted by trauma and it's been unrecognized, it can result in a host of behavioral as well as physical health impacts. As they mentioned in the introduction, I have the pleasure of directing a program that is school-based. And we know that trauma significantly interferes with academics, with learning, with just social interactions, with regulation and their interactions with authority figures. And so it's really important to be mindful of that, as well as other impacts to our physical health, cardiovascular disease, diabetes, obesity, and it has a number of other impacts as well that we'll talk more about. So when we think about the impact of trauma on adolescents, these are some of the common responses that we might see. And what can be hard about this is we don't always recognize it as trauma. So oftentimes we might have kids come into our clinic because they're considered a behavioral problem, or they're considered a loner, or perhaps they're considered as someone that has an issue with authority. And all the while we're kind of missing the underlying issue, which is trauma. So as you can see here, it might take the form of reckless or risk-taking behavior. It could take the form of the teen living for today and not tomorrow. Poor decision making. But it can also take the form of more compulsive types of behaviors, such as sexual behaviors, self-mutilation, binging and purging, even suicide attempts. So it's important for us to recognize that it is difficult at times. Trauma doesn't look one way. So that's why we're going to talk about some ways that you can talk with your teens, by asking them particular questions, as well as giving them some assessments to try to go underneath and see if there might be trauma. And the other thing I want to say here is it's not so much just that a teen has been exposed to trauma, it's the impacts of the trauma. So most of us, if I were able to do an informal poll, I would, pretty much guarantee that most of us have had one traumatic experience, but it doesn't impact us all in the same way, and we might not be dealing with a level of toxic stress. So I want you to recognize that in this talk, I'm talking about teens that not only have been exposed to trauma, but are experiencing toxic stress as a result of their trauma. Just a little bit more here about looking at some potential negative outcomes, and we'll talk about ACEs, but I'd like to show this because this kind of breaks it up into different aspects. And what I like to tell people is, unfortunately, it can overtake and have an impact on your life in terms of health conditions, in terms of your risk behaviors, as well as socioeconomic challenges. So this is just demonstrating how if we can address and provide trauma-informed care, we have the opportunity to kind of disrupt these pathways for these negative outcomes. So there are various trauma types. So not only does trauma manifest itself differently for teens, there's different types of events that can be traumatic. And so sometimes, again, when we look at that word cloud, we might think of only maltreatment. So with maltreatment, we're talking about things like physical abuse, sexual abuse, neglect, be it emotional or physical. But trauma can also be being in a motor vehicle accident. I can't tell you the number of teens that have come to our clinic for treatment that were involved in what maybe others might consider to be a minor fender bender, but really has resulted in a traumatic response. Trauma can also be a national disaster, so being involved in a hurricane or a tornado or some type of flood or fire, something that happens to them. It can be a traumatic grief. This is when we've experienced the death of a loved one, but there's some aspect about losing that person that the young person is really struggling with, and it's having an impact on their day-to-day function. It can also be violence exposure. This is things like intimate partner violence. It can be victimization in the form of bullying. And also we know that in our community and in your community as well, we have, people who have migrated to our country and they have gone through horrific experiences to get to safety. So it's important to think about refugee or war experiences. So as you can see here, there are a myriad of trauma types. And it's difficult, you can't look at a person or a teen and know what they are. So it's important to have an awareness of these various trauma types and think about ways we can potentially assess for them. So I want to just give a word about ACEs. This is a nice infographic from the Robert Wood Johnson Foundation. And so ACEs, we know, are adverse childhood experiences. And this was a cardinal study that was conducted several decades ago with an adult population. And what happened in a major healthcare system in the state of California, they were noticing that there were a group of adults that, irrespective of the treatment that they were giving them, evidence-based medicine, the approaches, that these adults were really struggling. They weren't getting better. They seemed to have more chronic illnesses. And so they began to do some research on these adults that were receiving services in their health system. And so what they found is when we think about ACEs, they kind of put it into three main categories. So they put it in the category of abuse, neglect, and household dysfunction. And so oftentimes people will like to give what they say is an ACEs survey. Like, I'm just going to take those 10 questions, I'm going to put them on a sheet, and I'm going to give them out. I'm going to give you a word of caution about doing that, because we're going to talk about some research in a minute in the sense that ACEs aren't always equal, especially for teens. And as I mentioned before, it's important to recognize that, you know, in the purpose of this Cardinal study, they found that the adults who were at greatest risk for these adverse behavioral and physical health outcomes, they experienced 4 or more ACEs. But some of the concern with the adolescent population, if we're not careful, we can take this research and we can say, okay, we're going to ask these questions, and we're only going to put those teens on our radar that have had 4 or more. So again, I would caution you against doing that. I think it's important for us to think about ways that you can screen and talk with your patients and learn about their experiences. But there's not good research, especially as it relates to adolescents, to suggest that there's a magic cutoff score. So I'm going to just pause there for a minute, because I know that, you know, oftentimes I give these talks and people get excited, and I'm glad that you get excited about it. But I want us to be informed and recognize that that is not an evidence-based approach to think about this Cardinal study and apply it to teens and think that 4 is the cutoff. Instead, I'd like to tell providers it's a way to get the conversation started, perhaps. It's a way to, you know, ask them information, but to always go deeper, or to involve a colleague, or maybe you're in an integrated practice, you can involve a behavioral health, but I wouldn't just do the screening and leave it at that, or think that you're going to flag certain teens because they have 4 or more. So as you can see down in the lower right, what they found though in the Cardinal study was that these adults who did have 4 or more of these adverse childhood experiences, they were at risk for a host of physical as well as mental health problems. So again, obesity, smoking, substance use. We also saw things like, you know, COPD, stroke, depression, suicide. So it's important for us to be aware of this study and its important contribution. And I think one of the important contributions is really thinking about the integration of physical and behavioral health care, because there was a time that we would maybe have some of these patients and think, oh, I'm just going to refer them to psych. They're not relevant in terms of my treatment plan. But what we're realizing is that, you know, these ACEs can get under the skin, if you will. And even for those that are medical providers, they can have implications for your treatment regimens as well. I want to say a brief word about, the literature is now expanding our notion of ACEs to think beyond adverse childhood experiences, also to adverse community experiences, as well as community environments. So this is meant to have us think more broadly about other experiences that teens might be experiencing. So for instance, food insecurity, housing instability, lack of access to technology. You know, that's a significant one now in our virtual and remote learning environments. And I know a lot of school districts are trying to be creative about this. In terms of community environments, thinking about poverty, discrimination, we've had a reawakening, if you will, to the plight of people of color in our nation, and thinking about the discrimination that they're experiencing. And this was ongoing. So again, this is a chronic adverse community environment that people are experiencing. And so it's important for us to think about those things that your teens are coming in the door with that is related to their lived experience, but also thinking about the intersectionality of their identities and what aspects of those might fall into their community and experiences and or environments. This notion here is also connected to thinking about transgenerational ACEs. And what that means is we can have teens that are impacted by trauma that they themselves didn't experience. It can be the trauma that their parents experienced, that their grandparents experiences. It could go previous generations. And so sometimes we might think about that in terms of particular ethnic racial minorities, but it's also just important to think about it more broadly, because we don't always know a child's family history as it relates to trauma. One way to think about this is when a child is coming in for a teen is coming in for an exam, and we oftentimes will ask about medical history and family history. And so I've been encouraging people to think about trying to have those same conversations with your teens as well as caregivers around what might be some generational family history as it relates to these ACEs, because it gives us an opportunity to have greater awareness and understanding of what these teens are experiencing. So for instance, we know from the literature that youth of parents who have had a history of ACEs exposure are significantly more likely to have increased odds for poor health status. Asthma was a particular diagnosis that was found to be more prevalent. And we also know that it's important to think about community resilience here, because we know that a supportive community environment can help to mitigate some of this intergenerational continuity of ACEs. And that's what we're trying to do with our school-based study, but there's things that you can do in terms of your trauma-informed care. So let's think about, as a first step in a medical setting, what might be something that you can do? My first recommendation would be to think about assessment. I really like this question that Cohen and colleagues put forth, because oftentimes it can be very challenging, to have a teen and maybe it's been a summer break, or maybe if it's even been the COVID break and they've missed some of their well child visits. And so you haven't had an opportunity to really check in and you have limited time. And so Cohen and colleagues suggest asking this question: since the last time I saw you, has anything really scary or upsetting happened to you or your family? And I can tell you that just by asking that question is very validating. It's very patient-centered, and it's letting the teen know that you care about what they have experienced, and you're giving them an opportunity to share. Now, obviously, some might say, well, no, I don't really necessarily have a relationship with a teen, or how can I expect for the teen to share something upsetting? I will tell you that you will be surprised how many teens we see that indicate that they haven't shared information with medical providers because they didn't ask. So I would encourage you just to ask the question. If they don't want to share the information, they will let you know. And perhaps they're just not ready in that visit. But the fact that you ask the question gives them the opportunity for the teen to realize you're thinking about them in a comprehensive way. You're thinking about their whole self, and you're thinking about other experiences they may have had that are impacting them. Some clinics like to go a bit further than that, and they say, you know what, we're going to do universal screening. And so typically when they do universal screening, they might do a brief self-report survey that the teen completes. It's usually less than 10 minutes. And depending on what this trauma-informed clinic is trying to do in their approach, they might focus on exposure, or they might go a step further and try to focus on particular stress symptoms and reactions. But the point of this is that the brief screening can help to guide your clinical decision-making, and it also gives you an opportunity to refer for more in-depth trauma assessment if you think it's indicated. Again, all of these practices, there have been studies that have looked at feasibility and acceptability for not only teens, but as well as their parents. And what research informs us is that teens and parents are very much open to medical providers asking these questions. These are just some examples of some screening tools: the trauma symptom checklist for children, the screening tool for early predictors of PTSD, as well as the adverse childhood experiences questionnaire. Again, as I said before, you just want to make sure that the way that you use these is not just looking for a magic cutoff score. It's really important to, look at it from a quantitative way, but also from a qualitative way, and to take note of experiences that might not be recorded in the teen's chart that they have had, because they could have implications for their health. Another point here is to think beyond, to think beyond the ABCs and consider what we call the DEFs. That's thinking about distress, emotional support, as well as family. And so again, by asking these questions in terms of distress, you want to consider grief and loss. As we know, we are going through a collective trauma as a nation. There are so many teens that are impacted by the COVID-19 pandemic. So whether you're having a virtual visit, I think it's important to consider grief and loss they may have experienced. And it may or may not be related to COVID. There have just been, a number of deaths that teens have experienced during this time, and they might not be COVID related, but it impacted their grief. They weren't able to do their typical family traditions and rituals. So it's important to ask about some of these questions. In terms of emotional support, you can be a collaborator with them to think about what are sources that they can go to, or what are maybe sources within your treatment clinics that you can social work or that you can refer them to. And lastly, you want to always be thinking about family. It's important from a perspective, obviously teens are maturing into adults and they are taking more responsibility for their health care, but we don't want to forget about their caregiving system and the stressors as well as resources, and think about how you can involve them. So next, we're going to move to thinking about realize. So remember, realize is thinking about the widespread impact of trauma. So we know from latest data that 2 out of 3 adolescents report experiencing a traumatic event by age 16. So all of those, that funnel that I showed you, those various different types of traumatic experiences, whether it's a medical procedure, it's an accident, it's a grief, it's some type of victimization, you know, any of those various trauma types, we have 2 out of 3 adolescents reporting that they've experienced one of those trauma types. We also know, as it relates to the ACEs, that 1 in 3 adolescents between the ages of 12 to 17 have experienced at least 2 or more. And so again, unfortunately, we know that it's highly prevalent in our nation. So it's even thinking about using these approaches. You know, sometimes I work with providers and they'll say, you know, well, Dr. Gibson, right now, we don't have time to do universal screening, or we don't have the resources, or, you know, we don't have the person resources, that if people are, you know, if teens are endorsing this, we don't really have a good referral system. And so I think it's important for us to be thinking about that. So obviously it's important for us to think about the barriers, but I would still encourage you, in terms of your provider to patient relationship with your teen, that having an awareness of their whole selves is going to help your care. And so I would still encourage you to try to ask the questions so you can understand what they have experienced, what they have witnessed, or what they have learned about. And it helps your relationship in terms of trust, and it has implications for adherence to your medical interventions. So as I mentioned earlier, we want to be mindful that what we're most concerned about is teens having traumatic experiences, but then it resulting in toxic stress. This is the stress that there's, you know, just a bevy of research that shows that it can get under teen skin, and it has implications for their physical and their mental health. So that's what we're talking about. It's have they experienced, but also how they are responding to what they have experienced. And are they at risk for, or are they already at an elevated level of toxic stress? Related to that, in our medical setting environments, we want to be very mindful of trauma reminders. And the reasons why we want to be mindful of that is because you can have teens engaged in healthcare with you that are experiencing a trauma reminder and giving you a reaction that maybe you don't quite understand. So let me just take a moment to talk a little bit about what trauma reminders are. So trauma reminders can be people, situations, places, or things that evoke past traumatic events. I also think it's important to think about our 5 senses, because oftentimes when a teen is experiencing a trauma reminder, their senses are being evoked. It's something that, you know, that's coming in, information that's reminding them about the traumatic event. It could be a smell in your office. It could be a sound if in a virtual visit. I mean, it can be any of these things. And that when a teen is faced with these trauma reminders, they begin to re-experience. And they begin to have intense and disturbing feelings that are tied to that traumatic event. And as I talked about before, you know, teens might respond in a number of ways. So they might respond recklessly, meaning they might begin to take more risk or abuse drugs or alcohol. We've had recent teens come through our clinic, and our trauma and grief clinic, that are involved in the legal system, because unfortunately their trauma reminders and their traumatic experiences weren't being noticed. and they didn't get the proper care and time, and unfortunately they had poor decision making and engaged in things that resulted to them now being a part of our legal system. They may withdraw. So again, it doesn't look one way. Another teen's reaction to trauma reminders is they start to withdraw more. And they do this in an effort to try to avoid these reminders. Some teens fear their strong reactions. We've had a number of teens that when faced with the reminder, they might have what we call a panic attack, and they feel that they're going crazy or they might die. And obviously there's the risk that they may feel stigmatized by having gone through these traumatic events, and they haven't shared them with anyone and they haven't talked with anyone. So that's why we're saying this is an opportunity for you to start that conversation. So I would just ask you to consider what might be some examples of trauma at reminders that teens might experience in your medical setting, be it in person or a virtual visit. It sounds like a little bit later, you're going to be talking about how to do, a trauma-informed assessment. Some of those things just for a routine exam can be a reminder to a teen, whether it was sexual abuse or some intimate partner violence, having to remove clothes, maybe there's something about the setting, maybe having to lay back, just any of these various experiences. And so some of the things that you can do to try to help to mitigate these experiences is to give the teen the rationale. Tell the teen what you're going to do and why you're going to do it. Be mindful of any reactions that you might be seeing that the teen is experiencing and ask them about that. So you might say, hey, I noticed that your eyes just got really big when I just explained what we're going to do next. Do you have a worry about that? And so these are things that you can do, and these are things that you can do even if you haven't screened a patient, even if you haven't, asked that key question that Cohen and colleagues recommended, you can still be collaborative and give the rationale for what you're going to do and why you're going to do it, and be noticing any observable signs of distress or discomfort and to query about that. Okay, we're going to move on to recognize. I think I'm doing okay on time, but I'll go through a little quicker. So here we want to talk about recognizing the signs and symptoms of trauma. For the sake of time, I'm not going to read all of these, but I will make sure that you get a copy of them. So these are the 12 core concepts for understanding traumatic stress responses in childhood and adolescence. And this is the abbreviated version, and I will provide the facilitators with the detailed version. But I would encourage you to look at these because they're very informative. So I'll just maybe read a couple. So like number 1, traumatic events are complex. They consist of many moments that are filled with different sensations, thoughts, emotions, and behaviors. Number 5, youth with trauma histories are often preoccupied and distracted by concerns about danger, being protected, and safety. So again, this can come out in your experiences. Number 10, culture can powerfully influence how a youth experiences and reacts to traumatic experience. And number 12, I want you to think about yourself, that working with teens exposed to trauma can cause distress in providers, and it can make it difficult to provide good care. But I'm going to encourage you to read all of these 12 core concepts because I think they're very helpful to getting us to increase our sense of awareness and moving to recognition. I think I'll just spend a moment on here. So again, this is just showing us some studies that were conducted with children into adolescents, and data that's just showing us that ACEs, even in present day, is being linked to 40 plus negative health conditions, many of the ones that I highlighted before. And this also demonstrated what I had said before about, having the more than 4 ACEs had higher odds. But as I said before, we want to be mindful that, one can be powerful. There was a recent study that talked about how all ACEs aren't equal with teens. It was conducted with teens. And what it found for teens is that teens struggled when they had more of the maltreatment ACEs. And so it's just important for us to recognize that all the ACEs aren't equal, especially as it relates to adolescent development. And maybe they've had one only, but maybe the type that they've had is having a powerful impact. Okay, I'm going to move on to respond. So here we're talking about you need to respond by trying to provide trauma-informed care, and that's what we're going to be talking about today. So I alluded to this at the beginning of my talk. In the resources, I also gave you the link for SAMHSA's guide. This is a very instructive guide where SAMHSA has given us 6 guiding principles to a trauma-informed approach. And as I alluded to earlier, safety is number 1. But it also talks about how we can engage in transparency, how collaboration, empowerment, choice, and voice, how giving attention to cultural, historical, and gender issues in our policies and practices. So these are all things that we can do. And I recognize that this is a journey. This is not something that happened overnight. And actually, I'm going to show you a video that's going to talk about a recommendation of how you can do this in practice. Just give me 1 second. Okay. Okay, are you able to see this?
Yep.
Okay, great. I'm going to try to start it from the beginning.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, so lots of rich things in that video. Let me just get back to my, okay. Okay, can everyone see me okay?
Yep.
Okay, so lots of rich take-homes in that video. You know, one of the things you may recall is that she said it's gradual. These things don't happen overnight. I know here in the state of Michigan, we have the ACEs initiative, which means that there are trained professionals who can come into your organization, and I know they're doing them virtually at this moment because of COVID, and they can provide some of this education. And so I would encourage you, if you're in the state of Michigan, to utilize that resource. And if you're not in the state of Michigan, to think about what your state may be offering as it relates to the ACEs initiative, where you can have people provide education to your workforce. Other things that it highlighted that I think were also important is this idea of collaboration and talking, in this case, with your teen patient. Just like was demonstrated for us earlier, you know, maybe you'll do a focus group, or maybe you'll get a group of teens that you'll, you know, preview some content with them, get some input about, hey, you know, this is some signage we want to put up, or could you help us, or what's the best way to do this? So I would encourage you to think about ways that your organization can become trauma-informed for teens, and to think about ways that you can involve teens and parents in what you're doing. This is just another kind of multi-tiered approach that really talks about how at the base of it, it all starts with communication. And then from there, we can increase our understanding. We can move on with collaboration and understanding our role. We need to make sure we understand our own history. So in terms of thinking about transgenerational trauma, it's not just for our patients, it's for us as well. We can also be experience a trauma reminder based on an interaction or awareness of a particular teen's case or findings. And so it's important for us to have that knowledge. If we're having a particular reaction and we don't quite understand why, we need to examine that within ourselves and figure out, is there something about this particular teen or their case or their findings that's evoking a reminder for me? And then obviously the recommendation here for screening. I think, so do I need to try to wrap up in about 2 to 3 minutes for questions? I'm just trying to figure out the time here.
Yes, that would be great.
Okay, so I'm going to try to wrap up in a few minutes. So what I'm going to do now is just talk briefly about resist. We're at the last part. So this is, you know, resisting the re-traumatization of teens, as well as the re-traumatization of yourself and others that might be in your facilities. So I provided this link. This just talks about some organizational practices that you can engage in, many of them that I've talked about. So, you know, creating a safe environment, focusing on, I'll focus here on thinking about secondary traumatic stress in your staff, providing education and awareness about that. I'm going to give you an example of a tool that you can have them take. And then obviously on the right-hand side, what we've been talking about in terms of your clinical practices for teens, things that you can do. So briefly, you know, it's important. I know most of us aren't getting on flights these days, but if you remember when you were getting on flights, they would say, you know, in the rare instance that the cabin loses pressure, an oxygen mask is going to fall from the ceiling, to please secure your own oxygen mask before helping neighbors or others. And this is the same approach that we want to take as it relates to secondary traumatic stress. It's imperative that we're aware of our own trauma histories, our own trauma reminders, and we make sure that our oxygen mask is secure. Because if we don't do that, this puts us at risk for burnout. And lots of medical professionals are leaving the field because of burnout. And so here, I'm just encouraging you to focus on self-assessment, to think about ways that you can reduce and enhance well-being, and also emotion regulation strategies. So one of the resources that I provided, oh, I don't see it here, but one of them, let's see, one of them is the ProQual. Yep, here it is. So I'll make sure that you get this. This is the compassion satisfaction and compassion fatigue, as well as burnout survey. This is something that we administer in our trauma and grief clinic because we're training fellows. And so I do this with every rotation of fellows. We also focus on the self-care inventory. So I will make sure that you get these resources because it's very important for us to have an awareness of what we're experiencing. So I just want to remind us all that we are stewards, not just of those who allow us into their lives, but of our own capacity to be helpful. So I hope that what I had to share today was helpful, and I hope that we'll have some interesting discussion, as well as it'll facilitate what you're going to do later this afternoon. I will get these resources to the facilitators. And finally, I just want to leave you with an African proverb that I try to use as a guide for me. And that is, if you want to go fast, go alone. But if you want to go far, we must go together. Thank you.
Thank you so much, Dr. Gibson. We're going to open it up to questions now, so feel free to chat your questions into the chat box. And we'll remind folks that if you are looking for some of these resources are already available in the Crowd Compass page, our event page that's been linked in the emails that you received, as well as in the chat. Any questions from folks so far? I can kick it off with a question that I had, actually. I'm a social worker by background, and when I first learned about trauma, we talked a lot about triggers, and you had called them trauma reminders. Has there been more of a shift in language, or was that an intentional language change with that?
That is a great question, and there has been a shift in language. You know, we're learning that, you know, language matters, words matter. And using the word trigger wasn't really trauma informed. And so we're trying to move people away from using that word to thinking about trauma reminders. So I appreciate you picking up on that. That is a progress where we're trying to move.
That's great. Thank you. Everyone is just saying great job. No questions thus far.
Yeah, thank you. I really do hope it was helpful. You know, it's always hard. You want to present so much information, but you want to make sure that the information is digestible and that it resonates. And so I hope that it was. And like I said, I want people to recognize I've been doing this work for many years and been working now in a school system. It really is a process. It really is a journey. But I encourage you to start the journey. And maybe you even pick one of the 4 R's. You might say, hey, we're so in our infancy that we're just going to focusing on realize, because I don't even think that our organization realizes the effect of trauma on our teens. And that is a noble goal. And I would encourage you to do that.
I think that's really helpful, because often when we learn something new that also seems very sensitive, we can be so nervous to start or do something wrong. But we always say at AHI, don't let perfect be the enemy of good. And I think that is sort of what you're saying too, as long as we can take some steps to move forward on this, even if we're not doing everything or doing everything perfectly.
That's right. And also just to really involve the teams.
Yeah.
You know, I just think the way you started off this morning was excellent modeling for all of us. And I would encourage people to continue to do that in your healthcare facilities, is to involve teams. Maybe you have a teen advisory board, or, you know, some type of way that you can really get teens' voices. Because I can tell you, I mean, I'm getting other school districts, I'm consulting with 2 other school districts, that this is really a prevalent issue in our society. And teens are so aware of how they've been impacted by trauma, and they want to talk about it. And so it's really a right time, even before COVID, that teens were really focused on, they're focused on their behavioral health, they're focused on their physical health, they just really understand how much mental health is impacting all areas of their life.
Totally. So a couple of questions are coming through that,
Okay.
they're from the same person, but I think this sort of goes back to having enough time to help the young person kind of process. So the question is sort of around like, if we're in a busy clinic setting and there are so many other patients waiting to be seen, how can we help young people unpack these things a little bit and address these needs when we're sort of strapped for time?
Yes, I think that's a really great question. And that's why I do want to say it's important to be very mindful and really figure out your plan. Like, I wouldn't want someone to take this and just try to put it all into practice. But what I will say is it's using the same amount of time, but it's interacting with them in a different way. And some of this takes practice, obviously. But even the question that I said that Cohen and colleagues recommend you ask, you maybe are asking, you're asking questions, but you're not necessarily asking that question. So I would say that part of it is just being, you have to be realistic about the time you have, but figuring out how can I kind of transform the way that I'm interacting with my patients. And you want to start small. So that's why I'm saying I would maybe start with a question. And then to their point, you do want to think about like, okay, if a teen starts sharing all this information with me, what is going to be the next step? One thing that's important for you to do is just to validate what they're sharing, and just to let them know that you see them and you hear them. And also, if you have the time, you want to think about who is a supportive person. What is happening oftentimes for teens is they're engaging in what I call maladaptive coping. And you want to try to ask them questions that get them thinking about more adaptive or positive coping strategies. So I agree that you do have to be thoughtful about this, and hopefully there'll be some time this afternoon. But I would say, asking that question about change, and then maybe trying to elicit, definitely validate, for sure, validate what they've shared. Make sure you take note of it so you don't forget it, because that's another thing that we work with providers on. You have to make sure that when a teen tells you something that you've got to take note of it so you can remember it. And then you've got to think about, do I have a little bit of time to help them think about ways they can engage in adaptive coping? Because a lot of times they're cutting, they're just doing lots of high risk behaviors because they're trying to cope with what they're experiencing. And then obviously the next step, and that's going to be different for every health facility. So that's why it's important to think about your practice and your setting, because it's really great if everyone can get on board with becoming trauma informed.
Thank you so much. I feel like you said so much in that moment too. I'm thinking about how easy it is to lose trust with young people with something like not remembering that they've disclosed a trauma to you. And so that really is sticking with me also. Thank you. Any final questions? And if not, then we'll move into our time for break.